Well friends, today we'll see what is cholangitis and what are different etiological factors which cause cholangitis and what are the treatment options available for them. So cholangitis occurs as a result of biliary tract bacterial infection in a setting of biliary tract obstruction. So what are the factors and what is the pathophysiology behind the cholangitis? Along with the sphincter of Oddi, the bacteriostatic properties of bile and bile flow, they are important components to maintain the sterility of biliary tree. So whenever there is absence of obstruction to the biliary tree, so bile flow itself will cause sterilization of the hepatobiliary tree. But whenever there is obstruction to the hepatobiliary tree, the obstruction itself will cause bile stasis and it will add to the cholangitis. As the biliary pressure rises with the obstruction, bacteria and their products such as endotoxins leak into systemic circulations and they cause septicemia or cholangitis. So whenever there is obstruction, the intrahepatic or biliary tree pressure rises, leading to the leakage of endotoxins in the circulation, leading to the septicemia of cholangitis. Patients with partial obstruction have higher chance of developing cholangitis than those with complete obstruction. So this is very interesting fact. So if you are given a choice, which of the following situations are likely to present with more chances of cholangitis? They may give you option partial obstruction of hepatobiliary tree and complete obstruction of hepatobiliary tree. So it is the partial obstruction which will cause more chances of cholangitis than complete obstruction, because there may be transit of bacteria across the bile duct and the distal small bowel. So there will be more transition of the bacteria across both them in partial obstruction. So if complete obstruction is there, there may not be chances of transition of bacteria across the obstruction. So patients with partial obstruction have higher chance of developing cholangitis than those with complete obstruction. And bile duct stones are associated more often with cholangitis than neoplasms causing obstruction. So here are two very important facts. Partial obstruction have higher chance of developing cholangitis and bile duct stones have more chance of causing cholangitis than neoplasms which can obstruct the biliary tree. So we'll see what are different causes for cholangitis or obstruction. So choledocholithiasis is the most common cause. So if you are asked question which of the following causes most commonly seen in cholangitis, so it is choledocholithiasis. So stones in the biliary tree. Then comes obstructing periampullary tumors. Then tumors metastatic to the porta hepatic region. Then peripancreatic lymph nodes. Benign strictures, primary sclerosing cholangitis can cause recurrent attacks of cholangitis. Biliary tract interventions may lead to the post-procedure cholangitis. Along with hemophilia, then presence of parasites in the biliary tree such as ascaris and congenital abnormalities of biliary tree can cause cholangitis. So there are various factors which can cause cholangitis. So among which the choledocholithiasis is the most common cause. Now we'll see various organisms responsible for cholangitis. So Escherichia coli is the most common organism seen along with Streptococcus species, Klebsiella species. Then Enterobacteriaceae are the most common organisms cultured in cholangitis. So Pseudomonas species and skin and oral flora are more commonly seen after biliary tract interventions. So if you are given a question, which of the following organisms are seen most commonly after biliary tract interventions? It is the Pseudomonas and skin and oral flora. They are not the Escherichia coli, they are not Streptococcus, they are not Enterobacteriaceae group. It is the Pseudomonas which is seen more commonly. So this is very interesting fact. So they may be asking you various questions depending on these findings. Anaerobes are seen in elderly after biliary surgery. So one more interesting fact. So which of the following organisms are seen most commonly after elderly or after biliary surgery? They will give options like various organisms along with anaerobes. So anaerobes are seen most commonly in elderly after biliary surgery. So various types of biliary surgery. These can be hepaticojejunostomy, then choledochoduodenostomy. So all these surgeries performed in elderly people. So they most commonly cause of infection or cholangitis is anaerobes. So what is the clinical presentation of cholangitis? The classical described is Charcot's triad, which is fever, which is seen in 90% of the patients, right upper quadrant pain seen in 70% of the patients, and jaundice, which is seen in 60% of the patient. So this percentage is very important because they may ask you in how many percent of people or how many percent of patients in Charcot's trial you will get fever, or which is the most common presentation in Charcot's trial. It is fever. Whenever patients have hypotension along with altered mental status, which is seen in septic patients, these are known as Reynolds pentad. So whenever there is presenting of two additional features along with Charcot's triad, it is called as Reynolds pentad. So these are mental obtundation and hypotension. So which is the most common investigation to diagnose cholangitis? Ultrasonography is the first investigation, but CT scan is better than ultrasonography at determining the level of biliary tract obstruction, and it has got 94% accuracy in diagnosing choledocholithiasis in a setting of suspected bile duct calculi. So CT scan is better than ultrasonography. But friends, MRCP is still better than CT scan. But in case of acute cholangitis, its role is limited. So if you are asked a specific question, in cases of acute cholangitis, which is the better investigation to diagnose, it is CT scan. ERCP should not be used solely as diagnostic tool in a setting of acute cholangitis. So whenever you want to do some therapeutic intervention or to treat cholangitis or to treat obstruction, then only ERCP should be contemplated. What is the treatment? First, you have to resuscitate the patient. So if the patient presents to any of the Charcot's triad or Reynolds pentad, then patient has to be resuscitated with adequate amounts of fluid, antibiotics. Then drainage of the biliary tree is the mainstay therapy for patients with acute cholangitis. So whenever there is obstruction, you have to drain the bile which is obstructed. It can be drained by endoscopy, percutaneous techniques which are transhepatic, or by surgical drainage techniques. So amongst all these, endoscopic, which is ERCP, is most commonly performed. So whenever there is obstruction to the biliary tree which is lower down near the ampulla of water, the endoscopic method is most commonly used. But if the obstruction is higher up at the biliary tree confluence, it is the percutaneous transhepatic biliary drainage which is done most commonly. Friends, now we'll see sclerosing cholangitis. So it is a disease characterized by inflammatory strictures involving the intrahepatic and extrahepatic biliary tree. So whenever intrahepatic and extrahepatic biliary tree is involved, it may lead to the sclerosing cholangitis. It is a progressive disease that eventually results in secondary biliary cirrhosis. So these repeated attacks of cholangitis will cause fibrosis in biliary tree, leading to the secondary biliary cirrhosis. So these are primary sclerosing cholangitis, seen most commonly after ulcerative colitis, which is seen in 2/3 of the patient. So of 2/3 of the patients of ulcerative colitis, primary sclerosing cholangitis is seen commonly. It can be seen with Riddle's thyroiditis along with and retroperitoneal fibrosis. It can be also seen with autoimmune reaction, can be associated with chronic low-grade bacterial or viral infection or toxic reaction, and genetic factors like HLA antigen associated with primary sclerosing cholangitis. So you may be asked various questions: in which of the following patients is seen primary sclerosing cholangitis? They may put any of these options along with some non-answerable questions, like they may put you ulcerative colitis or along with any of the disease combinations. So you have to pick up ulcerative colitis or Riddle's thyroiditis or retroperitoneal fibrosis or some autoimmune cause in the answering of the primary sclerosing cholangitis. So age of presentation is of 30 to 45 years. Men are affected twice as common as female. The usual presentation is intermittent jaundice, fatigue, weight loss, pruritus and abdominal pain. So these are very indicative of obstruction which is occurring repetitively. So friends, when a patient has got ulcerative colitis, if you perform colectomy, so it makes no difference to the progression of the primary sclerosing cholangitis. So whatever amount of colectomy you do, how early you intervene, it has got no consequence on the progression of cholangitis. So in the laboratory measurements, elevation of alkaline phosphatase and bilirubin are seen most commonly. During endoscopic retrograde cholangiography, it may reveal multiple dilatations and strictures along with beading of both intra and extrahepatic biliary tree. So confirmation is seen on endoscopic retrograde cholangiopancreatography. The hepatic duct bifurcation is often the most severely affected segment. So, if you are asked question, which of the following sentences are true? So, you may be given various sentences. The hepatic duct bifurcation is the most commonly affected or most severely affected segment. It may be one of the segment along with some non-specific sentences. So, there can be various permutation combinations of questions on primary cholangitis. A liver biopsy is done to determine the degree of hepatic fibrosis and presence of cirrhosis. There is no known effective medical therapy for primary sclerosing cholangitis and no known curative treatment. Corticosteroids, immunosuppressants, ursodeoxycholic acid and antibiotics have been disappointing. So friends, there is no definitive treatment to primary sclerosing cholangitis. Biliary strictures can be dilated or they can be stented either endoscopically or percutaneously. So whenever patients present to you with biliary strictures, they can be dilated. If the patient has got recurrence of dilatation or recurrent dilatations along with strictures which are recurring very rapidly, they can be offered treatment of anastomosing the strictures. The non-dilated segment can be resected and dilated segment can be anastomosis to the bowel. Surgical management with resection of the extrahepatic biliary tree and hepaticojejunostomy has produced reasonable results in patients with extrahepatic and bifurcation strictures. But the patient should not be having cirrhosis or significant hepatic fibrosis. So whenever the underlying comorbidity is not seen in form of biliary cirrhosis or hepatic fibrosis, these patients can be offered various types of anastomosis like hepaticojejunostomy. So they have better prognosis than the patients those have cirrhosis. In patients with sclerosing cholangitis and advanced liver disease, liver transplantation is the only option. So whenever there is advanced disease seen in form of severe liver cirrhosis or liver cell failure, only treatment option remains is hepatic transplantation. Friends, now we'll see post-cholecystectomy biliary injuries. So this is very interesting factor and various types of questions can be asked based on which of the following sentences are true. So this is very important session. So we have got classification of Bismuth and Strasberg. Those who describe the what are types of classification of the biliary tree injury. The drawback of Bismuth classification is that patients with limited strictures or isolated right hepatic duct strictures or cystic duct leaks cannot be classified. So you may be asked question, which of the following sentences true, and various types of sentences can be formed on this only one single sentence. Or they can be asked question, which of the following is the drawback of Bismuth classification. So they may include other factors and this sentence can be included. The next classification is Strasberg classification. The Strasberg classification is able to classify all types of injury and it is used extensively in describing bile duct injuries associated with laparoscopic cholecystectomy. So you may be asked question, which of the following classification is used most commonly seen after laparoscopic bile duct injuries. So they may be giving option transverse classification, Bismuth classification, and they may add any other classification seen in surgery. But it is the transverse classification which is seen most commonly for describing post-laparoscopic bile duct injuries. So post-cholecystectomy bile duct leaks, they occur from slipping of ligature from cystic duct or from bile duct injuries which go unrecognized at the time of surgeries. So there may be various abnormalities of bile duct formation, so which may not be recognized at the time of surgery and bile duct may be injured inadvertently. Initial investigation of the choice is CT scan abdomen and ultrasonography. So the first investigation will be ultrasonography at the bedside to detect what is abnormal going on in the patient. But once you diagnose there is bile leak, so choice of investigation to assess the further will be CT scan of the abdomen. Any biliary collection or subhepatic abscesses should be promptly drained. So whenever you diagnose any biliary collection and the patient is not having drain in situ, the bile duct collections or biliary collections should be drained immediately. Minor collection after drainage may not require further treatment if patient improves. So whenever there is small amount of biloma which may be forming after some ooze from the GB fossa, so it will self-limiting itself. So if you drain that collection and nothing is required on further treatment if nothing collects afterwards. If a patient has got major leak, jaundice and signs of cholangitis, then patient should be investigated with ERCP to evaluate presence, extent and severity of bile duct injury. So whenever there is prolonged formation of bile duct leakage, so whenever the bile duct leakage which is there, which continues for more than 5-7 days, they should be investigated further. Transected bile duct smaller than 3 millimeters or those draining single hepatic segment can be safely ligated. So if during surgery, if you are detected that you have damaged bile duct, if it is less than 3 millimeter, it can be safely ligated. If the injured bile duct is 4 millimeters or larger, it is likely to drain multiple segments or an entire lobe and thus needs to be reimplanted. So this is very important segment. So how do you manage the bile duct which is of 4 millimeters? So they may be giving various options. It can be safely ligated or can be stented, or they can give option like reimplantation. So if the bile duct diameter is more than 4 millimeters, so it can be reimplanted. Reimplanted means it should be anastomosis. Anastomosis should be done with any of the small bowel loops. Lateral injury to the common bile duct or the common hepatic duct recognized at the time of surgery is best managed with T-tube placement. So friends, during dissection of the Callus triangle, if the bile duct is damaged laterally, so lateral injury to the common bile duct or common hepatic duct. So lateral injury to the common bile duct or common hepatic duct at the time of surgery is best managed with T-tube. So if the duct is damaged, you can put T-tube across the bile duct. If the injury is small, then incision of the duct. So if the incision is very small, then T-tube can be placed through as if we are doing formal choledochotomy. So whenever there is small amount of injury occurring in the bile duct, the T-tube can be placed across the injury. In more extensive lateral injuries, the T-tube should be placed through a separate choledochotomy and injury is closed over T-tube to minimize the risk of subsequent stricture formation. So whenever there is very large amount of duct which is damaged, you have to put T-tube to separate incision. So and this injury should be closed along with this T-tube stenting the part of damaged duct. So when you stent across, the stricture formation will be less. So you may be asked question, if the bile duct is damaged very much extensively, which of the following will be correct approach? They will be giving you options like closure of the bile duct over it, primary closure of the bile duct, or putting the T-tube across the cut of the bile duct, or they may be giving you correct option of putting a T-tube across a separate choledochotomy incision. So separate choledochotomy incision will be appropriate answer in a setting of extensively injured bile duct. So cystic duct leaks can be managed with ERCP and stenting or re-laparoscopy and ligation of the duct. So this is very important because they may be given you clinical scenario. So if the patient which will present after 4 days with fever and ultrasonography detects a small amount of collection, what will be the appropriate line of management? So cystic duct leaks are suspected, which are most commonly occurring on the 4th or 5th day. They should be managed with ERCP and stenting, or they can be managed with re-laparoscopy and ligation of the duct. But whenever you are giving these two options like stenting or re-laparoscopy, ERCP with stenting is better option than re-laparoscopy. But sometimes when you are given an option of re-laparoscopy only and ERCP is not given, then re-laparoscopy is the choice of answer. 100 ml of bile output in the drain on the first day should be closely observed if the patient is clinically stable and output decreases over next few days. So if there is biliary injury and if you have the drain which is 100 ml in the first day and which will decrease over next few days, they should be safely observed if the patient is clinically stable. But if the patient has got decreased urine output along with decreased bowel sound and tachycardia, they should be explored accordingly. If the drain output remains 100 ml of the bile over 5 days, it denotes bile duct injury and requires ERCP. So here one more clinical question can be formed. If the patient has got cholecystectomy done and patient has got 100 ml of drain which will be continuous daily for 5 days, which of the following will be appropriate line of management? They will be giving you option like putting a drain externally or ERCP or open exploration, or they may be given option like PTC, which are non-specific diverting clues. So proper answer will be ERCP. So patients who have got continuous bile leak after 5 days, the proper treatment will be given by ERCP. So initial investigation of choice for a post-cholecystectomy biliary stricture is CT scan. So if the patient presents to you in delayed format in a form of biliary stricture, the most common or most commonly done investigation should be CT scan. Why it is CT scan, not other investigation? Because CT scan will give you information regarding any vascular injury which is seen along with the bile duct injury. MRCP is not helpful in this scenario. In a sense, the CT scan will give additional information of the atrophied lobe or any dilated biliary tree proximal to the biliary injury. After CT scan, next investigation should be MRCP, but CT scan should be first investigation. So there can be various questions. If patient presents to you biliary duct stricture after say 5 months, 6 months after laparoscopic cholecystectomy, then choice of investigation will be CT scan followed by MRCP. So friends, we saw various types of cholangitis, various types of biliary injuries and their treatment, and various combinations of management of biliary injury like placement of T-tube or primary suturing of the bile duct injury. Thank you.